25 minutes for discussion. I think we have, many of you have many questions about vaccines, about program managing, screening. How does it work in the practice? I encourage you now to use these 25 minutes to ask us and come up with your experiences about these strategies. Please come to the. Who is the first? Complex. Yeah, we have. Could you please identify yourself?
Hi, I'm Mauricio Massa from El Salvador. I had a question for Nathalie. In that last slide that you presented, not the last one, the one before that, and you talked about following up HPV women doing VIA triage, and basically, are those questions answered, whether you would treat women with lesions that are clear and pleasant, or would you just treat everyone even though you don't see a lesion when you do the VIA?
Well, from the data we have at the moment, it's very clear that we'd better treat only women HPV positive who have also a VIA positive test. Otherwise, we really overtreat. So that's the data we have at the moment. It seems that it's better to treat based on the VIA. And follow up then, if a woman is HPV positive but VIA negative, then a VIA should be redone after 1 year to follow up. It seems, but again, I mean, that's a preliminary result that we have. The overtreatment is like crazy when we treat only based on HPV. You treat really too many women. And we are not sure of the benefit of cryotherapy yet. I mean, when you don't have a lesion.
Okay, thank you.
Please. Yeah.
Hi, I'm Megan Wysong Harris, and I work for Japago. On one of your algorithm slides where you were talking about low-income countries that don't have the DNA testing, are you recommending, or is WHO recommending 2 VIA tests before treatment? Because it looked like there was a VIA, positive, negative, another VIA, and then cryo and leap.
Yeah, well, I'm going to show you why I put that. How can I come back? I know. You have to go. I know. I think it will help to understand. I knew it's not this one. Yeah. Oh, well, this one. Mm-hmm. Well, why I put 2 tests is for this reason. It's because when you are this is an operational framework to introduce VIA and cryotherapy in countries. So at the primary healthcare level, you can do VIA easily. You cannot introduce cryotherapy everywhere at the primary healthcare level. It's too much in terms of equipment needed, maintenance, everything. So you really cannot have the single visit approach at the primary healthcare level everywhere in the world. So what we want to do is to have, and that's what is here, primary PHC is primary healthcare level. You introduce VIA, and the VIA positive woman can be referred to the secondary level where there will be cryotherapy. But in order to be sure of the cryotherapy, you need to perform a second VIA. So that's why there was 2 VIA. No? Other question.
So at those primary healthcare centers that have both VIA and cryotherapy, only 1 test is?
Absolutely.
Okay, yeah. Thank you.
Yeah, if you can do the single visit approach, no problem. You don't need 2 tests.
Good afternoon. My name is Vanessa Lugo. I work for Merck here in Puerto Rico. And I'd like some comments on the lessons learned from the national vaccination programs. Thank you.
Vaccination.
Should I guess I can. Yeah. So the sort of lessons learned that were common to all these 3 countries First and foremost, community mobilization was found to be essential for the success of the program. Education and communication, as expected, really was crucial because even with the education and communication, there were still many questions by the parents. There were requests to vaccinate boys. And in Rwanda, actually, the female teachers were requesting to be vaccinated. So there was even with the education and communication, there needed to be more. The other important lesson learned is that school-based delivery strategy also has its own set of challenges, and it does require another strategy to be able to cover those who are not in school. So school-based delivery doesn't cover everyone. As I was sort of, I went over really quickly, selecting the grade that includes the highest proportion of the target age is really important. So as in Rwanda, they thought they were targeting the 11 and 12-year-olds, but in fact it was mostly 15-year-olds and older. Coordination and planning with the education sector where there's going to be a school-based strategy is key. There has to be consideration of timing of vaccination around school closings and holidays. And then there's the issue of parental consent that has to be addressed. Not every country will require consent, but that's something that, if it is required, is going to be complicated with the school-based delivery approach. And then finally, just the fact that reaching absent and out-of-school girls, which who are probably going to be the most vulnerable because they're the ones that are least likely to get cervical cancer screening later, requires a lot of resources and planning. So those were sort of the three common findings from the countries.
I have a
Thank
question.
you very much. Yeah, Lucas.
Also related to the vaccination.
Mona, you were first in line?
I'm sorry.
Yeah.
Sorry.
Okay.
Will you comment as well on the lessons learned or preparation for increased screening parallel to HPV vaccination, given that mothers and caretakers who know about vaccination usually then demand screening?
Was that question for me? Oh.
Yeah, so my question is, some of the pilots have shown that then mothers or caretakers, women caretakers of the children who are being vaccinated, then also demand screening. So in parallel, what are the lessons learned? Should then the HPV vaccination programs include a preparation for an increased demand of these mothers and
certainly,
women caretakers?
The strategy needs to be comprehensive and include opportunities to educate women about screening and really depending on the delivery strategy, there's going to be different ways of accessing the women. In most of these cases, the school-based strategies, the parents weren't really involved that much, so there was fewer opportunities to really educate the parents. But prior to vaccine introduction, there's campaigns to educate sort of the community in general, including the parents. So there are a lot of opportunities to educate the mothers about the need for screening.
Yeah.
You know this, the issue of mother-daughter, that has been discussed a lot, but in fact you cannot focus the strategy on that. There is a study ongoing in Thailand on how you increase vaccine coverage with involving mother, and how the same way you can increase screening coverage in the mother. And you can, of course, it's synergistic, but you cannot base, in fact, it's difficult to base your national strategy only on that, so it's got to be considered as a complementary strategy to your main strategy, which is school-based and information for women to go to screening on cervical cancer. So there is some synergy to explore, but it's not your mainstream strategy for that. So.
Thank you. Mona, you were next. Please.
Yeah, I have a question. First one for Nathalie, and then I have one for each of you, actually. My question is about the decision-making tool for countries. You've said that they can screen once, twice, 3 times in a lifetime. In your guidelines, will you have any kind of verbiage on how to go about deciding how many times to screen in a lifetime for a woman? Or is that an individual country decision?
No, there won't be anything because we don't have data on that. The minimums, we know the interval between negative screening tests and we know how to follow a positive screening test. But we are not going to say that once in the lifetime is enough, around 35 or between 35. We cannot say that. In fact, we don't have enough strong evidence to say that, even if we think it's right, but we won't say it. But we say women that are screened with VIA or cytology and the test is negative, she can be screened after 3 years. But that will be all the lifelong. Yeah? We're not going to stop at even, and that's why we're starting also the new recommendation after 50, because we need, because as you know, the limitation of VIA with the columnar junction, so we really need to have a recommendation for women that, for who you cannot do VIA. So that's.
Okay. Oh, and just to follow up, Nathalie, in the US, for example, guidelines to not do something have sort of taken hold, in terms of do not screen women under 21, do not use HPV testing. Are your guidelines framed at all in that way for younger women and or older women?
Well,
because there's one thing to say screen between ages 21 and 64, and another thing to say do not screen under 21, or whatever you say.
Yeah, we're trying to gather evidence to be able to say not screen before 25. But the issue that we have, as it's global recommendations, and we've got to take care of HIV prevalence, and that we would recommend to screen HIV positive women or from a high prevalence country at any age, as soon as they know that they're HIV positive. So that's going to be a tricky issue.
Well, most of the guidelines say HIV is an exception to the rule, but
find a way to say it. But that's.
And then for Andreas, my question to you is: it's wonderful now that the NCD indicators are in place for ensuring coverage at least once or possibly more in a life for women between ages 30 to 49. It seems to be very consistent with the WHO guidelines going forward. Will there be incorporation of that indicator language, et cetera, into the new Pink Book guidelines?
The language of the indicators in the Pink Book, we can mention it. It's a different process. The guideline development goes through the GRC. And
no, I meant, just
the
mention
indicators is more a political discussion also, of what is feasible, and it's a debate between the health attachés of our member states. So we are serving as a secretariat where we say, look, this is the evidence, this is our guidelines, but we cannot influence the debate as such. If they decide, our member states, which they want to have a screening indicator, not a target, that's this problem, then we say, okay, fine, and if you base it on this age group, that's fine, that's your decision. Huh? And then we underpin whatever they want as tools to implement the indicator, following their advice. It's a little bit this kind of relationship between the secretariat and our constituencies, because they say, okay, we delegate the technical work to the secretariat, but we decide what we want to do in our countries or at a global scale. The indicators are global, and it's not excluded that the countries have their own indicators. It's not in stone that every country needs to have the same indicator as it goes. It gives a global direction. I think it's a political decision, and to include this is a positive movement. What worries me is that it's not integrated in the targets, because just monitoring what is without having a direction specific to cervical cancer probably will not have a similar impact on the burden if we had a target on cervical cancer.
Can I just add something on that? With the indicator of cervical cancer screening, because it's a very important question, in fact, in the last guideline that I was showing, quality assurance, quality control for VIA and cryotherapy-based program, we recommend 3 indicators. One is screening coverage, the other is screening positive rate and treatment rate. So these are the 3 key indicators. And we align the screening rate with the NCD indicators, or the global frame, so that we've got exactly the same phrasing, and we're trying to precise a little bit more the one which is in the global framework. I mean, we're trying to have, because even, yes, it's true, countries are not obliged to have all the same indicators, but if you want to monitor at the global level, and we want this indicator very nicely, well collected, we try to have the same phrasing.
This is for Nathalie. On the VIA that you talked about, that you can, if you cannot have cryotherapy in most of the health facilities, rather you can just do VIA in certain facilities, and then if you find a woman with VIA positive and eligible for cryotherapy, then you refer her to another facility where that can be given. Has the cost of, follow-up, women will come and then you tell them to go, that's a cost to a woman. She's going to move to another center, further, more transport, more time. Is there evidence of how many women are we losing in this process? Yeah. That it could be cheaper, that having cryotherapy in their facility is actually cheaper than referring them to another center?
Well, this is a very good point, and we looked at that. We just published a report on the work we did with 6 African countries, and one of the aspects of the operational work was that one. And it's absolutely true, we lose a lot of women between the moment where they are screened with VIA, they are VIA positive, and to go to get cryotherapy. It's a huge number of women. It's about 40% of the women that we lose. So it's not neglectable, and it needs really active investment from the healthcare provider to really be sure that women are going to get cryotherapy. So that's one lessons learned, very important. You really need to be proactive in having the woman to go to the cryotherapy. Now, is it more costly to do that than to have the cryotherapy at the primary healthcare level? The issue with cryotherapy equipment, that it's got a cost, and you need to have good maintenance, and sometimes the lessons we have learned also is that you need at least 2 equipment where you provide cryotherapy. So it's not that obvious to have at any level. But some countries got the capacity to have it, or some settings have, but not everywhere.
Just maybe a comment. We have had the cryotherapy machines in most of our facilities for over 6 years, and we haven't had to replace any of them. So it might be just, I don't know, maybe it's there, or it's just actually not there, that we have to keep replacing these machines, but the nurses have been using them for 6 years.
But I can tell you, that's why we published this technical specification guide, because there was so many problems with the machine, with the procurement, with the maintenance, with all that was a real issue, sincerely. So maybe not everywhere, but in many countries it's an issue. It seems to be, at least.
Because the issue of loss to follow-up is very, very high.
It is, I agree.
I would be concerned about referring them to another facility.
No, I agree. Where are you from? Where?
Zambia, yes. Yes.
Oh, yeah. But,
I have a question, yeah. Yes. I'm Dương, I come from Vietnam. I'm very interested in some very good example of the vaccination campaign for some countries such as Rwanda, Bhutan and Malaysia, with the donation of the vaccine from the Merck company. But I would like to know how those countries continue to maintain the vaccination for their country after this vaccination campaign.
Yeah, thank you. That's a great question. And actually, the countries that I mentioned are actually countries that are eligible for Gavi funding, so for Gavi vaccination. And so, as you know, Gavi, which is the Global Alliance for Vaccines and Immunizations, and it provides vaccines at low cost to countries, has opened the window just as of this year for Hpv vaccine introduction. And so there were 2 ways that a country could apply for this. One was to to have a national introduction if they already have the ability to demonstrate that they can deliver 3 doses to this target population, or if countries have not had that experience, then they can apply for a demonstration project through Gavi. And so the countries, for example, Rwanda, they're still in the Merck donation phase, but what they intend to do is then continue vaccinating using Gavi funding. Probably the same with Bhutan. Most of the time, whenever there's a Merck donation, there's some commitment from the Ministry of Health for long-term vaccination, not just to have it for 3 years and then stop.
That means they can assure the vaccination in their country by government budget, right?
Yeah, usually the MOH commits to providing vaccine one way or another.
But budget is not available yet, right? Or
vaccine is not available yet? What do you mean?
Budget from the government is to be sure, or?
No, not yet.
Not yet.
Right. But it will be. I mean, once the donation program ends, then some other mechanism will kick in. In Bhutan, actually, it was just a 1-year Merck donation program, and what they did was they got a commitment from the Australia Cervical Cancer Foundation for 5 more years of support for vaccination. And then beyond that, I mean, I think all these countries were expecting for Gavi to start supporting and for the cost to decrease, which they are. In Latin America, there's, the PAHO revolving fund, as you heard this morning. So there's expectation that the countries will be able to support it long term.
Yeah, thank you.
Yeah, please.
Hello, I'm Pema Lucky from Nepal. And I just have a question. I mean, it's a follow-up to his question. Is in Nepal, as you know, that we are eligible for the Gavi, and I've been working, trying to convince the people in the government to apply for the Gavi so that we can get the vaccination at a cheaper rate. And I just want to explain or sort of share with you the problems that we face, and maybe get your advice that when we go there saying, yeah, it's good, we should get apply for the donation that, the price cut that Gavi is giving. But they said that we have so many other vaccinations that we need to prioritize. And so they are right in that perspective. And then so they say, yeah, we'll apply for Gavi. And then at the end of it, we don't have any funds, And so how are we going to be? And we cannot start a sort of a program or an initiative if we know that 5 years down the line, we don't have the capacity to continue doing it, So that is a problem that we are facing, and I face every time. And I just would like to get your advice on how we should actually work on this and take it further, because we're interested in it, but our hands seem to be tied from all directions,
Yeah, absolutely. I mean, obviously that's one of the biggest barriers in low resource settings. I mean, there are competing priorities, and it's really, really important for the country to make the decision of whether cervical cancer and other HPV diseases are a big enough priority to commit to HPV vaccine introduction. I mean, absolutely, there are other new and underutilized vaccines for childhood that a lot of countries have not yet introduced. So that's a big concern. And again, it's just something that the Ministry of Health, along with the political leadership and the community leadership, needs to really look into and decide if it's the right thing to do for the country.
Just add something?
Yeah.
Maybe it's good news, but it's got to be followed up. There was a meeting 2 days ago in Southeast Asia with many countries of Southeast Asia, including Nepal. So the Ministry of Health, representatives from the Ministry of Health were present, and they're really discussing seriously what they will do for cervical cancer prevention program, because it's not only the vaccine they don't have, but it's also all the screening and all the treatment. So voilà. So there will be a national meeting in 2013 in Nepal to discuss this issue and what will have to be done, which priority, which district will be prioritized, etc. So that's a discussion which is ongoing.
Okay, thank you very much. We are at the end of this fascinating session. I hope we gave us a little bit of insight how WHO works on guidance and guidelines, and how does it relate to the new NCD agenda. And the NCD agenda, I think, with the monitoring framework and the action plan, will support this prioritization and of course will raise also major, tough questions about the dichotomy of the communicable diseases and non-communicable diseases. Thank you very much for your attention.